Hello everybody and welcome. My name's Barbara Munro. I'm Chair of Compassion in Dying, and it's my pleasure to be chairing this webinar today. DNACPR seems to be in the news more than ever at the moment, and to be one of the most emotionally charged topics in medicine at the moment. We're all accustomed to seeing depictions of CPR as a dramatic process in which people come back to life on films and on television. But while CPR is a life-saving treatment, the data on actual survival is rather grim. If CPR isn't performed within 4 minutes of cardiac arrest, there's a possibility of brain damage. Fewer than 1 in 10 people survive an out-of-hospital cardiac arrest in the UK. And only between 14 and 26% of people who have a cardiac arrest in hospital survive to leave hospital. So it's probably not unsurprising that many doctors say they would refuse resuscitation. It's interesting to note that while treatments with things like antibiotics and chemotherapy are only offered when appropriate based on evidence and as part of person-centered care, CPR seems to have become a treatment that's almost given by default. In a recent multi-country study, 600 clinicians were asked to recall their most recent patient over the age of 80 who'd received CPR. The physicians were asked how they felt about their decision to perform CPR or to withhold it. Although only 2% of the patients survived long enough to leave hospital, more than half of the physicians still stood by their decision to administer CPR. In the light of that often cited first do no harm principle, something doesn't seem quite right about that. And then when I hear reports of 80-year-olds being shocked and distressed by a doctor wanting to discuss the issue of CPR or advanced care planning with them, I worry that something's gone really wrong in the public's understanding of both CPR and attempts to provide personalised care. This isn't to blame the public or doctors, even though there have been examples of very poor communication by some doctors and care providers during this pandemic, and of course, long before it. It's also not to blame the media, even though lots of news stories undoubtedly make the problem more difficult. I think it's indicative of a wider problem in our society, whereby we put off important conversations about our thoughts about medical treatment and what we want at the end of life. To be clear, the decision about whether CPR is appropriate to be offered to a patient is a clinical one for doctors to make, and patients can't demand any treatment, CPR included. However, DNACPR decisions must, by law, be discussed with and explained to the patient or family, other than in very limited circumstances. So we absolutely must have these conversations. However, discussing CPR in an emergency room is far from ideal. These conversations should really start much earlier, calmly and thoughtfully, so that each person gets the care that's in line with their goals and preferences. It's one of the ways in which we can try to achieve what most of us want, which is a peaceful and supported death. So we're here today to ask, what can we do to bridge the gap between public and healthcare professionals' understanding of what CPR is and how likely it is to be effective? How can we bridge the gap between public and professional understanding of how decisions about whether or not to attempt CPR should be discussed, made, and recorded? And what systems and attitudes do we need to move forward in a positive and constructive way? So that's an introduction to this really, really important topic that we're discussing today. And just a few housekeeping rules before we move into our speakers. First, we're going to hear from our expert panelists, and each one of them will give a 5-minute lightning talk. And then when they've all spoken, we'll open up into a discussion so that you have the opportunity to put your questions. Because we've got so many people attending today, we won't be able to see you or hear you, but we would like you to get involved by putting your questions. Please ask them using the Q&A function. This might be at the bottom of your screen, or if you're using a different device, it could be somewhere else. You can ask a question at any time, including while people are speaking, and we'll answer as many as possible when everybody has finished speaking. Please try to keep your questions succinct so that we can respond to as many as possible. And when asking your question, do let us know your name, perhaps your role or something about why this issue is important to you. We've disabled the chat function due to the number of people attending, but the Compassion in Dying team may put messages there for you to see. And finally, if you'd like to share your thoughts on social media during or after this webinar, please use #ImportantConversations. Now, I'm going to introduce each of our speakers in turn. And first of all, it's a pleasure to introduce Kate Masters. Kate has personal experience of the distress caused by DNACPR orders not being discussed with the patient or family. She's seeking judicial review against the Secretary of State for Health and Social Care, asking for better public information to be made available about CPR-related decision-making. And clearly, whilst Kate is able to reflect on her family experiences to date and to explain what she hopes this case will mean for patients, their families, and the doctors supporting them, she's obviously not able to comment on the legal aspects of the case, which will be decided by the court. So Kate, over to you. Thank you.
Thank you. Thanks, Barbara. So my name is Kate, and I'm going to tell you a little bit about my mum's experience of do not resuscitate decisions. So 9 years ago, I knew nothing about DNACPR. On the 7th of February 2011, my mum, Janet Tracy, was diagnosed with terminal cancer and given 9 to 12 months to live. 2 weeks later, she broke a bone in her neck in a car accident and had to be admitted to hospital for treatment of her crash injuries. Within 2 weeks, she had died. During Mum's time in hospital, she had 2 DNACPR decisions made about her, but neither was discussed with her. A doctor spoke to my sister and me separately about the first DNACPR, but never used the term. Mum was intubated, and they tried to remove the tube unsuccessfully a few times. And he said, "As we speak, we're removing the tube, and if your mum struggles, we will increase her sedation and she will slip away." We now know that he thought Mum was going to die, not just be resedated, although I don't think either of us really understood that at the time. The tube was successfully removed, and by the afternoon, Mum was sitting up chatting with the nurse about pastry recipes and asking for a Burger King. A couple of days later, my sister was chatting with a nurse, and the nurse said, "Don't worry about the DNACPR." It seemed that it was something that had been put in place following the conversations we had had, but it had never been mentioned. This was a shock. My sister asked for it to be removed. We would not have added anything to Mum's medical notes without asking her. From then on, DNACPR became to me the form. We thought that was that. Mum's wish to have the form removed was the end of the conversation, but it wasn't. At every opportunity, a doctor would ask Mum or us separately, but not as a family, about the form. They said to her that she would die in the hospital. They said that it was the cancer. Mum wanted them to talk to her with Dad there, but they always talked to her when she was alone. On one day, there were more mentions of the form in Mum's medical notes than any other aspect of her care. Her pain medication wasn't helping and she wasn't sleeping. All the doctors wanted to talk about was the form. All we wanted to talk about was Mum. Mum was scared by the conversations. She felt badgered. Is it right that someone in a hospital gown, in a hospital bed, should be scared about any aspect of their care? Eventually, we asked the doctors to stop talking to Mum about the form when she was alone. So they didn't talk to Mum again, but they did keep asking us. They would start with, "What do you know about your mum's condition?" And I would say that she had cancer and a broken neck. They would say that CPR would break her bones, burn her chest, and that she would be in a vegetative state, and that we would have to decide to turn off the machines. and they would ask if I wanted to do that to her. This made me wince, and it still does. All I could say was Mum did not want the form. She had made her decision. 3 days before Mum died, a consultant told us that Mum had maybe 2 to 3 weeks to live and said, "Where do you want your mum to go to die?" We set a plan in place for her to go to a hospice, but this was Friday evening and nothing would happen till Monday. 2 days before Mum died, a doctor spoke to most of my family about the form. She was someone we trusted and she apologised about the way it had been handled before. Still, all I could say was Mum did not want the form. After Mum had died, we found that this doctor had written another form. She had written on it that we all agreed. She also wrote the forms for the Liverpool Care Pathway, and Mum died on the 7th of March 2011. My sister was with Mum only through her sheer determination that Mum shouldn't be alone. My dad wasn't there, neither were my 2 other sisters, and neither was I. None of us got to hold her hand and tell her that we loved her, and none of us got to say goodbye. After Mum died, we realised that this form, the DNACPR, should have been limited to just a decision about her receiving CPR, but was actually pivotal to her treatment and care at the end of her life. DNACPR seemed to be the decision that opens up the chance to make choices about important decisions, such as where and how you want to die. DNACPR is so much more than just a form. Another thing we discovered after Mum died was that there was no right for her to be involved in the discussion. Dad decided to take a legal case to change this, and since June 2014, it has been a legal requirement for people to be involved in DNACPR decisions. Since Mum died, I've struggled to remember anything but those last 2 awful weeks of her life. 9 years on, I still relive every detail of what I've just told you. I now have long-term conditions of my own, but I struggle to go to the doctors because the ambiguity and coerciveness of the conversations in Mum's last 2 weeks have completely destroyed my trust in doctors when it comes to my own care. I know so much more now, and I can pick out specific conversations from that time and think, I wonder if what they're actually telling me there was that Mum was dying. 9 years on, it's all still very real. And 9 years on, I'm still here trying to make sure people get a better deal than my mum. Before Mum died, CPR was just one of those terms that lingers in your memory somewhere. Like most people, I would say, oh yes, I know what CPR is, but I never really knew what it was. The fact that CPR is not a cure-all for death is tough enough to get your head round without adding in the complexity of explaining that a DNA CPR withholds a treatment, so doesn't need patient consent. Since Dad started his case, I've believed that people need clear, accessible information about the process of DNA CPR, their right to be involved, an understanding of that tricky consent conundrum, that it does not affect other treatments, that it should not be made just because of age or any kind of disability, and what to do if you don't agree. I believe that this knowledge would help these important conversations along by removing the fear that some people feel when the issue is raised, leaving doctors free to chat with people about the clinical reasons for their decision and concentrate on making plans for their future care and treatment. Knowledge, as they say, is power. I do not believe it is a doctor's responsibility to provide policy information, and to that end, I have asked the Secretary of State for Health and Social Care, Matt Hancock, to provide information relating to DNA CPR on the NHS website. He has refused to do this, so I'm about to launch legal action against him to make sure that it is done. I'm driven to make a difference to DNA CPR discussions by the experience of watching my mum die in a place that she didn't want to be, without all the people she loved around her. My mum's death should have been so different. Mine and my family's legacy should be so different. Dame Cicely Saunders is famously quoted as saying, "How people die remains in the memory of those who live on." This has been my mantra for change for 9 years. Everyone deserves the best chance possible for a good death, and that starts with a good conversation.
Thank you, Kate. And that was a very powerful testimony to start us off from the perspective of the ill individual and the family. Thank you very much indeed. We're going to move on now to Upeka de Silva, who's been analysing the CPR-related calls made to Compassion in Dying's free nurse-led information line. Upeka is going to summarise what we've learned from the questions callers ask and the experiences they share. Upeka.
Hello, and thank you. So I lead the DNA CPR strategy at Compassion in Dying. I do analyze the calls that we receive on our information line, and I also have the privilege of speaking with people who have been directly affected by both good and poor practice in this area. We have helped over 56,000 people to plan ahead, and there are two things that I have learned about CPR decisions from this work. The first, the status quo is not acceptable. When CPR decisions go wrong, individuals, families, and health and care professionals can all feel tremendously distressed. The stories on this we collect may not be strictly data, but taken together, they are a hugely significant indicator of a culture that needs to change. Secondly, and something that helps me feel optimistic, is that I have learned that it doesn't take much to get it right. And I'll come back to this at the end. So let me share a few examples of the types of calls we receive. They can be grouped into 5 key themes. First, people want to be protected from receiving CPR. Several callers have told us, if I die, I want to stay dead. And this is significant because a lot of the media reporting recently has focused on how people are scared of being given DNACPRs. But it's equally important to note that there are many people who understand exactly what CPR entails and do not want to be given this treatment. So when these people are not supported, it leaves them feeling ignored and abandoned. Here are some examples. This lady said, "My sister asked about a DNAR at the hospital. They said, 'This is a hospital, not a hospice. We make people better.' Another lady said, 'I'm 87 and I don't want CPR. My GP told me it was not a necessary choice for me to make at this point in my life. I feel very anxious.'" The second theme is that not having a DNAR form can cause serious harm. One person told us, "Just before he died, my 88-year-old granddad was resuscitated many times. I am still angry that a DNAR was never discussed with him or my nan at the care home. It meant he had to live through 3 weeks of fits, bleeds, and losing his dignity." Thirdly, when distressed family members call us, they are not demanding CPR. They simply want a sensitive explanation of why CPR will not be given. One caller said, "The doctor told me it's a medical decision and that's it. Why couldn't they just speak with me?" So I feel it's not always accurate to portray family members who are unhappy with the DNACPR order as people who are outraged by the decision itself, because we know from the people we support that all they often want is a proper conversation. Fourthly, we get questions from healthcare professionals. We get questions like, does the form travel with the patient to different care settings? Do we need to complete a respect form and a DNAR form? Where do we get the form from? But we also get calls from professionals who are anxious about not giving their patients a peaceful and supported death. And the final theme is that coming to an understanding about CPR with people undoubtedly results in a better experience for that person and their family. Done well, DNAR conversations help people understand what is likely to happen if they become unwell, and it gives them the chance to ask questions and explain what matters to them. Good conversations also focus on what treatments and care will be given, and not just the fact that CPR won't be attempted. Recently, a caller said, "When my husband was in hospital, a doctor tried to explain to me that he should not receive CPR. I wasn't ready to hear it. I wasn't ready to lose my husband. But I am grateful to that doctor for sowing an initially uncomfortable seed, which has since germinated. My husband didn't need CPR, but we now have plans in place that reflect his values, and the future looks brighter." So, to end, here are a couple of reflections based on what I have learned from our callers. Many problems we hear about on our information line arise from a culture of benign paternalism. Nobody has set out to cause harm, but ultimately that's what's happening. That culture of not supporting individuals to make their own decisions and not consulting on care plans must be challenged. And not just by individuals like Kate and organizations like Compassion in Dying, but also by all the professionals and journalists who know how to get this right. And finally, complex problems don't always need complex solutions. If we are outraged by the stories of poor care and we're able to empathize with those in distress, then I think we can certainly find a better way forward.
Thank you, Upeka. I think really important comments there about clear and accessible information and about respectful conversations. And we're now going to move on to Ed O'Brien, and Ed is a paramedic and end-of-life care lead at the Welsh Ambulance Trust. And he's going to share his experiences of the realities of what happens when paramedics are called at 3 o'clock in the morning and when difficult decisions need to be made in extremely challenging circumstances. So Ed, thank you.
Yeah, thanks very much. So yeah, I'm Ed. I'm a paramedic based in Wales. I've been asked to share my thoughts on DNACPR decisions from a paramedic perspective. So I guess a paramedic, if a DNACPR is presented to me as a paramedic, it says that someone who knows the patient better than I do has discussed CPR with that patient. And that was at a time when they were able to explore options and gather the patient's thoughts, if they had capacity to do so, that jointly it's been concluded that CPR would not be appropriate and that the patient wouldn't want it. So when an ambulance clinician arrives on scene, we know very little about that patient. We might know that we're going to a collapsed adult, perhaps a patient that stopped breathing, and that's about all we'll know. We won't have any background information, medical history, etc. So we've got very little time to gather information when we get there. And of course, we're always going to default to life whenever there's an element of doubt. So, you know, we may change that thinking once we gain further information, but it's highly likely that we'll have started CPR at the time. By the time that we've gathered enough information to say, look, CPR is futile and it's not in the person's best interest, we've already started because we've needed to get further information. So when reviewing the effectiveness of a decision support tool, which is effectively what a DNACPR is, I do often refer to the 3 a.m. decision, as you've mentioned. And what the 3 a.m. decision is in the context of ambulance world is an ambulance clinician that's perhaps been working since 7 o'clock the last night. They've been extremely busy, they're tired, they've had a difficult shift. I guess I'm saying they're not at their peak. Even in those circumstances, a DNACPR form is an instantly recognizable form. It says CPR is likely to be futile and it's not what I want. So, but of course, DNACPR only kicks in at the point when the heart stops and the patient's no longer breathing. Prior to that point, we will do all we can to ensure comfort, dignity, and to manage symptoms. A DNACPR helps us to quickly recognize die-in over cardiac arrest. So I guess for clarity, what I mean by that, a cardiac arrest is a patient where everything's working really well, somebody like I, for example, and all of a sudden I just drop down dead, and that's a cardiac arrest. Die-in, it's kind of the opposite. It's when the body's shutting down, all the systems are failing, and the heart's kind of one of the last things to go. So CPR in the context of cardiac arrest is likely to be absolutely the right thing to do. And if I collapse, absolutely, I want CPR. But CPR doesn't work on a dying patient. It serves only to give false hope to those relatives that may be present. CPR is brutal. It's still the right thing in cardiac arrest because a person that can be potentially saved should receive all the treatment, even aggressive treatment, if that's what it takes to reverse it. It's in their best interest, but CPR on a patient that's died, that's not in the patient's best interest, and it won't work. A properly documented DNACPR decision helps a patient to achieve a good death, a dignified death, one where family can be with them at the point of death, as opposed to being perhaps stood in a corner of the room watching ambulance clinician press up and down repeatedly on the chest, insert needles, administer medications, etc. Ambulance clinicians throughout the UK can make a clinical judgment call to withhold CPR, even in the absence of a DNACPR, but that can only be in specific circumstances. So if the patient has conditions unequivocally associated with death, that might be rigor mortis, for example, but we can also withhold CPR when a patient's known to be in the final stages of an advanced and irreversible condition. But therein lies the issue. If the patient is known to be in the final stages of a terminal condition, it's likely we've never met that person on arrival, but we've the patient's not breathing, they've only just stopped breathing. The chances are we're going to start CPR as we begin to information gather, because we're always going to default to life until we've got the information we need to make an appropriate decision. A DNA CPR removes a huge chunk of that information gathering that we need to do. The information gathering's been done. It's been done prior to the point when we really need to know if CPR is the correct next step or not. A DNA CPR helps promote a dignified death for patients with palliative conditions, patients that are dying of irreversible causes. A DNA CPR won't prevent anything else other than CPR though. So if a patient has a DNA CPR and they become poorly and 999 is used, we will still attend and we will prioritize your call based on your clinical need at that time. The DNA CPR will make no difference to how we prioritize your 999 call. If your call is down to difficulty in breathing, for example, you'll be prioritized exactly the same as you would be as a person without a DNA CPR. When we arrive and follow an assessment, if the patient's got a likely reversible cause, even with a DNA CPR, we will still do all we can to treat that reversible cause, including transfer to hospital if that's what's appropriate at the time. So I guess I just want to conclude and say, I want to try and reassure people that a DNA CPR helps an ambulance clinician to respect a patient's wishes. It helps us to help patients achieve a good death, but it does not stop any other form of treatment, and it does not make you any less of a priority in comparison to a patient without a DNA CPR.
Thank you, Ed, for a model of clarity and accessibility, and for helping us to really emphasise how important good documentation is in getting a respectful death and treatment. I'd like now to introduce Professor Martin Green. Martin's the Chief Executive of Care England, which is the largest representative body for care homes in the UK. Martin's going to share his perspective on the impact that blanket DNA CPR decisions have had on care homes and the practical challenges associated with DNA CPR faced by people living in care homes and by those who care for them. Martin, over to you. Martin, you need to unmute.
Can you hear me now?
Yes, that's great, Martin.
Thank you very much, and apologies everybody for that. My technology is not working too well. Well, first of all, I want to say this is a really good opportunity to debate something which is really at the heart, I think, of an agenda which is about co-produced medicine and care, and also how important it is to have conversations between people and their clinicians and their carers. You know, regardless of whether the legal requirement is about doctors being able to make decisions because of the medical issues, the bottom line is that good medicine and good care is about co-production, it's about good communication, it's about people having the facts, understanding what the implications of those are, and making informed decisions. I think, you know, one of the things that Kate said, which really struck resonance with me, was if we get this wrong, the impact on carers and loved ones is enormous and long term. And if we get it right, we not only deliver really better quality end of life care, but we also deliver a better approach to how people can move on and have a positive experience and grieve properly. So I think we should acknowledge that this is a really important area for the communication and co-production between clinicians, carers, and families and people themselves. Now, one of the things that I think that does require, though, it requires a lot of communication between different bits of the system. And it also requires that communication to be happening sooner rather than later. I was really struck by that notion that somebody at 87 doesn't need to think about this now. I think one of the things we all need to do, regardless of how old we are, is to think about whether or not we would want to go through the trauma of DNA CPR, regardless of how old we are, if we had a critical incident that required it. Certainly in care homes, one of the challenges has been that sometimes the support from both the acute and also the primary care health services are not as good as they could be. and there is not that proper dialogue. Now, one of the things that's happened is, probably as a result of COVID and the way in which things are being speeded up, we're going to have the enhanced healthcare in care homes put into all care homes. What I would say about that is that I hope that will also respect the professionalism of care home staff and see them as a valuable and important part of the support to the resident and to the family. And let's have a conversation where all parties are treated equally and regarded as professionals, because only when we do that will we get things right for the residents, for their families, and also will we get better understanding of how different bits of the system should work to support people around end of life and CPA DNR. Now, one of the other things I want to say is that throughout this pandemic, somehow, probably naturally, because it is a crisis, we have seen some really bad practice. And we've seen some things like blanket suggestions that people should have CPA DNR put on their records. And there has been no individual decision made. It has just been a blanket decision. Now, this is completely unacceptable in any circumstances. And what we have to have is an approach which regards everybody as an individual. And we should be making decisions that are based on clinical need and position, rather than blanket decisions about whether or not somebody happens to be in a care home or indeed has several comorbidities. And I think one of the things that came out of Edward's presentation there was this is not about necessarily having comorbidities, it's about whether or not DNACPR will be able to help you to live well if you are brought to a point where you can return to a much more normal life. I'm really concerned, though, that because of the bad practice and because of the inevitable inquiry that will ensue after we get out of lockdown and we have got the Corona-19 virus behind us, we might find that there are some knee-jerk reactions that start to have blanket approaches which say, well, we're not going to engage in discussion, or we're going to give everybody DNACPR. And I think we have to be really vigilant about putting this whole issue into the choice, autonomy, control, and human rights agenda. And we have to recognise it's an individual issue based on clinical position and based on a full and in-depth discussion with not only the person, but also their family and carers. And we must also make sure that everybody who is supporting them in every bit of the system has the same information and also knows what to expect and how to respond in situations where DNA CPR might be potentially used. So I think what this crisis will have done is brought this issue into sharper focus, but let's have a reasonable conversation about it rather than a knee-jerk response. That's all I think I want to say, Barbara.
Thank you very much indeed, and thank you for emphasising the importance of the different parts of the system working well together and respectfully, and also the importance of remembering that this is about individuals and it has to stay, importantly, at that individual level. I want now to pass the baton to Dr. Mark Taubert, who's a consultant in palliative medicine at the Velindre Cancer Centre. He's an honorary senior lecturer for Cardiff University's School of Medicine and the founder of the Talk CPR initiative. Mark will share how he seeks to bridge the gap between public and healthcare professionals' understanding of what CPR is and how decisions are made about whether or not to attempt CPR. Mark, over to you. Thank you.
Thank you. I've not really prepared a talk, but I'm very happy to share some of my experiences and why I've arrived at this moment. In the preparation for this, there was a lot of talk about watershed moments for DNA CPR and coronavirus and what it all meant. And I thought back at some of my watershed moments when it comes to DNA CPR and why I became interested in the topic. And it went back as far as sort of the year 2000 when I started as a junior doctor in City Hospital in Birmingham. I think I learned a lot about CPR and DNA CPR in the doctor's mess there, of all places. You would have thought maybe I'd have learned a lot about it in medical school beforehand, but that wasn't the case. And perhaps I was initially biased, but the first CPR I got involved in the hospital, I was responsible for the chest compressions, and I have very large hands, so I felt the ribs give away underneath me without wanting to be too graphic. And this elderly gentleman survived, and he survived for another 3 months or so, and I was with him during that time because I was the junior doctor on his team, and I was always very surprised at the fact that he had survived and what he had achieved. But it gave me maybe a skewed view. I came out of it thinking, well, CPR is something that can work. Soon I would be, that illusion would be taken away, because I think the next 12 or so arrest calls that I attended, the CPR was not successful, despite all the efforts that were made. And at times in the doctor's mess, we would go back, we would be quite demoralized. Some of us, would be in tears about what we had just gone through and what we had seen and what some of the relatives had to witness in the A&E departments or resus rooms. And that really formed me for times to come. And I think even then I was someone who wanted to draw patients and their family members into these conversations. And part of my learning was also that I got it terribly wrong sometimes. So sometimes I was that doctor who perhaps did a terrible communication on a Saturday or a Sunday when I was the on-call doctor, and perhaps the team that had been looking after a patient hadn't maybe had that conversation with someone. But as happens so often, you learn through experience, and I learned through experience over the years in terms of how to talk through these things and what to do. And perhaps it formed me and kind of made me go into the specialty that I'm in today. I'm a palliative care consultant here in Cardiff in Wales, and I have these conversations a lot, and I teach about these conversations a lot, and I've learned a lot from the people I know and the patients and the patient representatives who work with me within Velindre, and the carers as well. And I wanted to say a big thank you, actually, Kate. You've taught me a lot, and we've been in email correspondence and in Twitter correspondence a few times. And thank you very much for some of the materials you've given me, the witness accounts from yourself that I've used in teaching. I used it when I was teaching intensive care trainees the other day, for instance. So thank you very much for that. And I suppose when I think about DNACPR, I think about you, and I think about Zoe as well. And the other person I think about is Mike Stone, who I don't know if he's listening or not, but if he is listening, hello, Mike. And it's kind of become like a little group of people that you think of and that you sometimes correspond with on this most dreary of topics. But dreary it may be, but there's still 200-300 people here today who on this afternoon have chosen to listen about this topic and who think is very important. So I suspect a lot of people who are in the audience today maybe have had direct experience of it and with it. So that's just some of my initial honest thoughts about watershed moments. And certainly during coronavirus and during the coronavirus outbreaks, I have had a few watershed moments as well. For my sins, about a year ago, I was given the perhaps uncomfortable responsibility of leading on the All Wales DNACPR policy, perhaps because I'd been so involved with creating the Talk CPR video resources with patients, and they are for patients and they are for healthcare professionals. So we'd filmed some videos really sort of having conversations about CPR and about DNACPR and what it meant, and really bringing across the fact that actually it's quite an unsuccessful intervention, but also talking about things like blanket approaches not being acceptable when it comes to DNACPR. And those kinds of things. Those videos were quite successful. They weren't just looked at in Wales, they were looked at worldwide really, and they've been used as a worldwide resource, so much so that we had to take the .wales, we had talkcpr.wales, but we managed to get talkcpr.com, talkcpr.co.uk and talkcpr.org as well, so that people in England or Scotland or Namibia didn't feel uncomfortable using something that had .wales or .cymru on the back. So it was kind of an international resource more. And so yeah, I was given last year asked by Welsh government whether I take on the All Wales DNACPR policy, which is a scary thing to do, believe me. And I said yes. We are currently in the process of updating the All Wales DNACPR policy. So whilst NHS England are still perhaps maybe, I don't know where they are at creating one, we're on version 4, and it can always be improved. I can tell you that. I've got lots of things that I would like to change and amend, and we've got a patient representative on our group who's got lots of good suggestions as well. But if you look at the current version, which is open to everyone on wales.nhs.uk/DNACPR, so easy to remember, I hope, you will see that there is express mention already of not having blanket approaches, and how important it is to individualize these conversations for one and all. Having said that, I must say CPR itself is an ageist procedure in its success. And whilst sometimes Ed and myself and other people who've been involved in CPR will always remember the people who've survived, and will be so happy when that has happened. But we also know that there's certain patterns of people, individuals, where it doesn't work so well, and I think that is then a time to take stock and then have these very honest conversations with individuals. And what I wanted to, yeah.
I think those are really important reflections, and you've emphasised for us really listening to patients and families, and also using patient and family experiences for training healthcare professionals and others, so that we're respecting people's experiences and using them to inform medical professionals. I think that's really important. I'd like to move us on now to Dr. Zoe Fritz. Zoe is a Wellcome Fellow in Society and Ethics and a consultant physician in acute medicine at Addenbrooke's Hospital. Her research on problems with DNACPR orders led to the development of an alternative approach to resuscitation and wider clinical decision-making, known as the RESPECT process. And Zoe's going to talk about what's gone wrong with CPR, what works, and what the future holds. Zoe, over to you.
Hi. So I am all of those, I am those things, but I'm not sure I'm going to talk quite as you said, because when I spoke to Natalie earlier, we said that I should focus on talking about how it's about shared understanding. And then talk about how we shouldn't talk about CPR in isolation, and finally talk about respect. So with only 5 minutes, I'm not going to spend the time explaining why I don't like DNACPR, although I will maybe mention it a bit. I'm going to focus more on how we can do things better. So first of all, why do I think it's about a conversation that's about a shared understanding rather than shared decision making? Obviously there are all kinds of areas where shared decision making is really important. So where someone's choosing what medication to start, or which operation, which procedure to have, or even whether they should enter in a screening program, then shared decision making is great because the doctor can explain the different options available, what the benefits and risks are of each of them. They can understand from the patient what's important to the patient, and together they can make a shared decision about what the next thing is. But CPR is really different than that, and we've had a few mentions of why that's the case. So Barbara, you mentioned at the beginning, a patient can't demand to be for CPR if clinicians think it's not going to be in their interest. And Ed, I loved your description of if someone is dying as opposed to having a cardiac arrest, then it's not going to be successful. You can't reverse the whole body process of dying by attempting CPR. And so a patient can't demand to be for CPR, and it's important to be able to have a conversation where you're able to explain that distinction. But it's also different because there isn't equipoise. It's not, well, you could have CPR or you could have something else in that event. It's you could have attempted CPR or you could die peacefully, I guess, is the alternative. But it's not a shared decision making, it's a shared understanding. And so there are kind of three things in the conversation that I think there are important in terms of establishing shared understanding. And the first is shared understanding of the patient's condition. The second is shared understanding of what outcomes the patient values and what outcomes they fear. And the third is a shared understanding of what treatments, what realistic treatments might be available to get the patient to the outcomes that they value and to prevent them from getting to the outcomes they fear. So I'm going to take a second to go through each of those. So the first is to make sure that both the clinician and the patient have a shared understanding of the patient's diagnosis, prognosis, and current situation. Because if you dive right into a conversation about attempted CPR without having a shared understanding of what's going on right now, you're going to have a rubbish conversation, because we've already had examples. So Kate has mentioned of where doctors use euphemisms and they go away from a conversation thinking they've said one thing and the patient or their relatives go away having understood something completely different. Unfortunately, most of us as clinicians have had examples of where we've said something like, I'm afraid we now just need to, the only option available is palliative chemotherapy, and we think it's been understood by the patient that they're therefore not going to get a cure from their cancer, and that has, unless you're explicit, that hasn't been heard. So a shared understanding of the diagnosis, prognosis, and current condition. The next thing is to get a shared understanding of what outcomes the patient values and what outcomes they fear. And I tend to say, in hospital, there are all kinds of treatments we can offer a patient. And in order for me to understand which ones you would benefit from, it's really helpful for me to know what outcomes you value, what outcomes you fear. And the patient might say, what do you mean by that? And I might say, well, for example, some patients have said to me, I don't want a lingering death. If my time comes, please let me go quickly. And other people have said, you know what, so long as I can wash myself a bit and recognize my granddaughter, keep me going. And those are really, really useful things to know. It's not about which treatment do you want. Do you want dialysis? Do you want non-invasive ventilation? Do you want invasive ventilation? It's impossible to go through all of those treatments. It's about understanding overall outcomes. So then the third thing is to get a shared understanding of what treatments might actually help that patient get to the shared outcomes. And you could say something like, in view of what you've just told me, I think that we should give you antibiotics and fluids, and we should give you all the simple treatments on the ward. But given that you've told me that you wouldn't want a lingering death, to continue with that example, I think if those aren't being successful, we shouldn't take you to intensive care and we shouldn't attempt CPR. If we weren't managing to get you better with simple treatments, we should make sure we allow you to die peacefully. And that brings me to the second point. CPR should always be in the context, should always be discussed in the context of overall goals of care, and Upeka mentioned this. I think there are all kinds of reasons why it has ended up being segregated and isolated on its own, and this red DNACPR form is one of them, because it does introduce fear to both patients and actually to doctors. Doctors don't like talking about what treatment we're not going to give. It's a much more comfortable conversation to talk about overall, how can we achieve a shared understanding of what outcomes are valued, what outcomes are feared, and therefore what treatments will get you to there. And so that brings me on to respect. So Barbara mentioned that some of my research had contributed to it. It has been not my research, this has been a massive project led by Resus Council UK. My research contributed to it, but so did that of Gavin Perkins and multiple other people who I'm not going to list, but I just don't want to, it wasn't the Zoe Fritz show. So the respect process, respect stands for Recommended Summary Plan for Emergency Care and Treatment, and it does what it says on the tin. So it is a process which results in a form. Kate mentioned that lots of the conversations are about the form. This is very much about the process. It's about a process which nudges clinicians and patients and their families to have the kind of conversation I'm talking about, to try and achieve a shared understanding of the patient's current condition, what outcomes they value, and what treatments will get them there, which can then be easily recognized in an emergency, so that ambulance clinicians and GPs and patients, doctors and hospitals can all recognize what an overall treatment plan is. So Barbara was right, I don't like DNACPRs. I mean, I really have a complicated relationship with them, having researched on it for 11 years since I was pregnant with my son. But the main reason is I think they're too blunt an instrument to deal with what is really a complicated situation, and they have too narrow a focus for what's such an important decision and an important conversation. So to summarize, I think to discuss CPR, you need to have a good conversation, and that conversation needs to make sure that it achieves shared understanding of the patient's condition, shared understanding of the outcomes that patient values and those that they fear, and a shared understanding of what treatments will realistically get them to the place they want to be. And as a tiny corner of that, you have to discuss CPR. That's me, thanks.
Thank you very much, Zoe. I think it's really interesting that we've bookended these contributions from our panelists, starting with in a sense, the horror from an intimate perspective of the form, and ending up with the importance of creating shared understandings. So thank you very much for that, Zoe. And thank you to all our panelists for really thought-provoking contributions. We're going to move into the Q&A now, but before we do, I just want to acknowledge that talking about these kinds of things can stir up all sorts of emotions sometimes, and it's really important for all of us to take care of our mental well-being. And if something has been stirred up for you, please do think about contacting an organisation like the Samaritans or Cruise Bereavement Care, or there's an organisation called Our Frontline for healthcare professionals that offers support and an opportunity to debrief. And more detail on all of those organisations will be available in the chat box. So moving on to the Q&A part of this webinar, can I remind you all to use the Q&A function and tell us a bit about who you are and why you're interested in this topic. And I'm going to read off some questions from my sidebar, so you have to forgive me if it's a bit clunky, and I'll kind of go through them and I'll indicate somebody I think might be interesting to answer that question. So let's see, this one is, I think it's going to go to Ed, and it's from Hermione Elliott from Living Well, Dying Well. And Hermione says, I very much appreciate this conversation and the contributions, in particular Ed's talk and his clarity. While the protocols are weighted towards default to life, we find that pragmatism and decisions to withhold CPR are not universally applied in the paramedical service. We frequently hear of very frail elderly people and terminally ill people who are put through the trauma of CPR. A question we're asked by family carers in relation to frail elderly and terminally ill is, am I doing something illegal if I give time and space to be with the death and I don't call an ambulance when my relative dies? I'd be interested in your response.
Oh, so the question's more on the legality of it.
Yes.
And I'm going to be honest and say, I don't know the actual legality of if that scenario was to happen. So if somebody did not call an ambulance, I genuinely don't know the legalities on it. Perhaps somebody else on the panel may.
Anybody else like to respond to that? Mark or Zoe, maybe?
I mean, I don't think there's any obligation for someone to call a paramedic. And I think it's a really complicated situation at the moment that while you're not under a legal obligation to call a paramedic, then sometimes when a paramedic arrives, the patient relatives feel they've lost agency in being able to determine what happens. I think you commented, you clearly don't have to start CPR, but I think there's work, and Mark mentioned Mike Stone, who feels very passionately about this. And in fact, we've just written something to try and make sure that there is better understanding that a relative absolutely contributes to or makes the best interest decision if they don't want CPR attempted, and you have good reason to believe it, even if there isn't a DNACPR present, you need to respect that relative's view.
And Ed, do you want to comment on the kind of broader perspective of the question?
So, yeah, I guess so. So the bit about paramedics doing, I guess, what was described as possibly inappropriate CPR, I suppose, is how we term it. Yeah, and I'm going to be honest in saying it does happen, and it shouldn't. And I think as ambulance trusts over the last few years, and I'm speaking for all 13 ambulance trusts across the UK, we all working together to build that educational package, because we've got a lot better than we were, but we've still got more work to do. I think when I talked earlier about how a paramedic can use the guideline of, okay, we don't need a DNACPR if we recognize it's the end stage of a terminal illness. So it's an advancing an illness that, something that's not going to get better. I think where we as paramedics need to get better is to recognize that end stage frailty is included in that. I think we're all great at recognizing, okay, and what's an advanced and terminal condition? Okay, that's your cancers, perhaps any dementias, and maybe we need to do more to help educate ambulance clinicians that frailty is also in that box.
Can I come in here briefly as well to say something about the Welsh ambulance service, Barbara? I work very closely with Ed. He works close by to me here in South Wales, and on a few occasions, Ed has kindly invited me to come on the ambulance, and I will make time for that. And in fact, a lot of palliative care staff have come along on the ambulance, and we do a quite collaborative. We have quite a collaborative approach. But very recently, for instance, that we've discussed a case, Ed, where you went in to the household and there was no DNACPR, but it was very clear that CPR was not something that was wanted. And the paramedic staff did a brilliant job and actually stayed in the household for I think 7 or 8 hours to support that person, make sure they had good care, good comfort care, liaised with palliative care, community clinicians, made sure that there was pain relief available. The role of the paramedic is far, far wider than what some people imagine, what they've perhaps seen from popular television programs. And certainly we've grabbed the bull by the horns in Wales in terms of really making palliators a hope out of our paramedic staff as well, because they're at the front line. I have a feeling Barbara has frozen.
I was just thinking the same. I think the chair has crashed.
Zoe, something you said struck me, and I completely agree with you. I actually don't like DNACPR forms at all, and the way we've approached it here in Wales, which sounds strange for someone who has to lead on the All Wales DNACPR policy, I know, but certainly in my teaching and when it comes to the Talk CPR videos, we've often said, you know, don't over-focus on the form. Forget about the form. When you're going into a conversation, that shouldn't be your outcome from the conversation. You should go in. You should talk to the individuals about what is important to them. CPR is just like this big noisy kid on the block that takes up all the attention in all of this. And actually, you need to mute that. You need to find out what they think and what they feel. I sometimes go into conversations with patients and relatives and say, look, you're feeling a bit better. You've had a recent rough episode here in the hospital or in the community. Actually, is now the time to talk about when you get unwell again, what you would want and what you wouldn't want. And then I talk about things like even coming in for a blood transfusion or a platelet transfusion or some intravenous antibiotics. And we work our way upward. And I think that's very much in the spirit of what you want to do with respect and the respect process as such. So I think
have a think about it in Wales then, Mark.
Yeah, that's right. But yes, absolutely. But and we do, and we are. But it's really. I
think the thing is, I'm really heartened to hear you say that, and I think education is exceptionally important, and a form on its own isn't going to do anything. Although I say the pen is mightier than the sword, but what is the power of a piece of paper? And we know that there are examples of where you can nudge people's behavior. And while you can educate people about all kinds of things, if you don't, in the heat of the moment, if all you're going to someone with is a red piece of paper that says don't do something, it's very hard to remember all the things you're meant to do. So our hope with respect is that it nudges people into all of those wider conversations. Happy to chat to you about respect in Wales, Mark.
Yes.
Quick plug.
Yes, no problem at all. Barbara has unfrozen, so.
I'm just waiting for my question bar to re-emerge.
There are a couple of questions we can see. Do you want us to?
Yes, please do.
Julia Grant, consultant in palliative medicine, says, how close are we in England to adopting respect nationally? So I've been very clear from the beginning. The problems that I see with DNACPR, I think meant that we needed to have another approach, but I didn't think there was enough of an ethical I think there's a real danger in making something compulsory, because as soon as you make something compulsory, it becomes a tick box, or it becomes something people just so we at RC UK and I were very keen that people chose to do it, and it's iterative and we keep on getting feedback. And in fact, we're working on a version 3 at the moment. And there are 150 trusts now using Respect in the UK. And I don't think it should be mandated as a national process, but I hope that people will want to continue iterating it and using it. So the second one's from someone called Katie Sunshine, who says, if you've made an advanced plan, including DNACPR, what happens if the hospital uses the Respect digital form, that's a very specific question, but in theory they should be able to overlap, but it depends on the economic systems locally. Anyone else have a question they can answer?
I think I'm seeing can you still see me if I've got my questions up?
Yeah, I can see you, Kate.
Okay. Yep. Well, there's quite a bit of information there. For instance, I'm looking at one from Claire from a care manager for people with learning disabilities, and she said a DNA CPR was placed on a patient who was admitted to a COVID-19 ward. When questioned about this, I was told there were different levels of DNA CPR, but where is this recorded? I think it's that confusion that I'm really trying to address, so that not just doctors are aware of what should be happening, but also patients and carers, because that's clearly not correct. You know, there aren't different levels of DNA CPR. She's possibly, you know, needing to understand the difference between care plans and DNA CPR. That's the thing that really concerns me, is people are very confused about the issues, and that's what breeds all of the mistrust and the problems. And this is where you get situations where people are finding these hidden DNA CPRs and undiscussed DNA CPRs, and that is something that I really strongly want to address with the legal action that I'm taking. It's just to basically put out there to people what their rights are, what should happen. You know, the fact that you don't need consent, the fact that it's only for CPR, that's the kind of thing that I really passionately want to get out there. Because when I see questions like this, I think, I understand there is still a lot of confusion. Once that goes away, I really think it's going to be an easier conversation around.
Kate, I would certainly agree with that. And certainly as well, what we've seen in this pandemic is people having blanket approaches just because of where they are in the system. So particularly care, you know, people who are in care homes being told, well, we're going to give the DNA CPR to you, not based on a clinical decision or a discussion. And in fact, I had letters, you know, where I saw GPs saying, we're not coming in, we're not going to send anyone to hospital. And by the way, put DNA CPRs on everybody's notes, which is completely outrageous. So there's some really important stuff like that that we need to flush out. Because that sort of thing is really unhelpful, and it doesn't help the process of the discussion, which is about how we talk to people and we get people to understand. Because I was really impressed, Zoe, with your approach and how you go through that bit, which is the start of the process, about where people are with their prognosis and where they are on their journey. And so often, and particularly with blanket approaches, and I've been really concerned about how some blanket approaches have been used for older people in care homes during this, and also learning disability services also.
I just saw one from Caroline Dent, and a similar situation. The question is it ever too early to put in place a DNA CPR and an advanced decision? Her GP was surprised that she wanted to do one, which is something that I mentioned and happens a lot on our calls. So really, supporting people, the short answer is it's never too early, I imagine. And putting something down in writing is always helpful, not just for you and your family, but for Ed and anyone else that cares for you. And I really feel strongly about everyone supporting people to have these conversations. So when a GP or someone else says, oh, don't worry about it, you're still young, you're not ill, it's really unhelpful. I know it comes from a nice place because they don't want you to worry about horrible things, but it's so important, and we should be really proud when people take this step, because it also challenges this idea that death is taboo, when in fact here are people, loads of people on our calls want to talk about it, want to do something, they just need the help.
And we often treat death and dying and the topic with sort of cotton gloves, don't we? And we're sort of very careful about it, even sort of going as far as making big disclaimers and saying, be careful, we're going to be talking about death and dying. But actually, in my practice, I often find when you get people talking about it, they have a lot to say on the matter. And it's you then sometimes get the phone calls from the younger relative in London. How could you talk to my mum about a DNA CPR form? And I often say, well, she actually really wanted to talk about it. She had a lot to say on the issue. And you might be quite surprised in terms of what she actually said to me. Often we find it most difficult to talk to those who are really close to us. And it's much easier to talk to a complete stranger like me or one of my team about some of these really intimate topics. And also how diverse we all are. Some of us really want to put our affairs in order and talk about ATRTs, advanced decisions, and DNACPRs. And other people find that topic quite off-putting and find it very difficult. And for me as a clinician and for the colleagues, it's often very difficult to broach the topic, perhaps without causing offense to some people. And sometimes I still get it wrong as well.
Okay, I've got a sort of cobbled together system now. Can everybody hear me?
Yes.
Yep. Okay. We'll have another go. So this is a question for Martin. Who is or should be regulating advanced care planning, and is it different for care homes from primary or secondary medical care? And is there a regulator missing in action?
Well, first of all, I think one of the things that's come out of this pandemic is the fact that our regulator sits in silos. We supposedly have an integrated regulator that's responsible for primary care, for acute services, for care homes, etc., as well as also things like dentistry. And what we haven't seen in this pandemic is we haven't seen them joining the dots. So I think there should be some form of regulation or some form of opportunity for somebody to be overseeing this issue. I was really interested as well. I noted that Julia Grant, who's a palliative care consultant, had made a point about how we haven't talked too much about this pandemic, but how it can be a platform for us all to talk more about things like, advanced directives, what we want for ourselves in care and treatment. And mainly because Julia said, this has suddenly come upon us, and people who thought they were looking at a long time into the distance, suddenly facing, COVID-19 and serious illness and a lot of recovery time, and in many cases death. So it does provide us with a platform, but I think the issue about the regulator is also an important one, and we need some kind of oversight of this.
Kate, is there anything else you want to add to that?
Yes, I think there isn't really anybody who regulates the quality of the conversations. You can probably get some stats now that you couldn't get 9 years ago of how many of these conversations are happening. But I think the qualitative angle is definitely missing. And I think the best people to really give you feedback on that are the people involved in the conversations. Obviously the patient, if they're still alive and walking around with the do not resuscitate, and how they feel about it. With regards to their own care and how the conversation went. And if not, the family. I mean, there are probably many families out there who don't share my experience, who are just going around their daily life because the conversation was handled well. But when it goes wrong, it can have life-changing experience, life-changing elements to it, which is why it's great to see people like Zoe and Mark, who are senior clinicians involved in trying to make things better, because they involve people, they involve patients and people before they become patients to help them in their work. And I think that's the value in what they're doing.
Thank you, Kate. This is a question for Ed, and it's from Janice Long. Where does this leave the campaign for defibrillators?
Where does this conversation lead?
Yeah.
So this is a completely separate thing. So I guess what I was trying to allude to earlier is there's a vast gulf of difference between cardiac arrest and dying. Defibrillators are the right thing for patients with cardiac arrest, and I wish there was one on every lamppost in Britain. I wish we taught CPR in schools, because in cardiac arrest, defibrillators are the right thing. For dying, something completely different subject.
It's really important, isn't it, that we get clarity about all of these things. And I think that's one of the things that we're saying in this webinar, is that people need clear, accessible information. Yeah.
Can I just say one thing?
Okay.
Is that I really loved Ed's description of the differences between natural dying and CPR, and the CPR that you get that might actually benefit from, the cardiac arrest that you get from might benefit from CPR. There's one doctor that I know that I have to say this every time I speak, and they say, you know, if you're dying of natural causes, CPR isn't going to work. So basically, if your heart is the first thing to go and you have a sudden collapse, then CPR might benefit you. However, if your heart is the last organ to go, then it's not likely to work. So CPR is just not likely to work. And that is something really simple for people like myself who's not very medically minded to understand. I think there really needs to be a big change of the language around CPR. And I am all for teaching children in schools about it, as long as the fact that death is also taught as well. Because with the likelihood of CPR working, I think it's quite dangerous to teach anybody CPR without teaching them the stats for it working. It's a great thing to know, a great skill to have, but people need to be prepared for the outcome not being a good one.
Okay, thank you, Kate. This is a question for Zoe. I work as a deprivation of liberty social worker, and I often come across DNACPRs on the files of care and nursing home residents, where residents who lack mental capacity and without friends or family are having DNACPR decisions made by GPs without the GP consulting anybody except other professionals sometimes, and not consulting anybody that might represent the interests of the residents. It seems this highlights a common example of either a gap in legal protections or poor professional practice. What do you think?
Well, obviously the law is that if a patient lacks capacity, then the person caring for them needs to make a best interest decision. And in order to make the best interest decision, they need to seek information from everyone close to them in order to be able to make a decision specific for that individual. So that sounds like bad practice to me, but obviously without seeing the examples, I'm very reluctant to criticize people without knowing the situation, but I'm happy to state what the law should be, which is that the person caring for the patient is able to make a best interest decision. There was a question, I'll just tag on to it, there was a question that I noted came up because I had said earlier that if a paramedic came in, that the family member, if they are the carer for the patient, they can be also making a best interest decision. That's what we're doing all the time. If we're looking after an elderly relative who has dementia, we are taking on the role of a carer who is making a decision about what to feed them or how to look after them. So they are critically important in making those best interest decisions. They don't lose the agency in doing so. Yeah. Just to add on the extra bit. Does that answer the question?
Yes, I think it does, and it just emphasises the importance of consultation and consultation widely. I think if there isn't a specific individual who's obviously the named person. This is a question for Kate. Can I ask Kate, I'm a GP, what single factor would have improved her experience with the doctors who were involved in her mum's care?
I think definitely more honest language. There are some things, I mean, certain words that you can pick up on that I think medics use that really don't transfer very well to people who aren't medics. And one of them is futility. And I try and bring this one up every time as well, because when somebody medical says that something is futile, that means that it probably won't work. But if you say that to somebody, that it can be, and is quite often misconstrued as being, well, I'm not worth it. Not that the treatment won't work, but that they're just not worth it. And especially when it comes to withdrawing something that is going to help somebody if they're dying, or potentially help them if they're dying, then that can be a really rocky road to go down. I think using the D word, death, it shouldn't be shied away from, because if somebody is dying, they are dying. And if the decision maker, because we have, my dad actually tried to get a national policy as part of his case 6 years ago, but it was turned down by the court. And because of that, every setting can write their own local policy. And that's usually left for the decision to be made by someone quite senior. And I think asking a question of, is the decision maker the best person to have the conversation? Because I think one group of people who are really left out of the conversation quite a lot, who shouldn't be, is nurses. They know their patients best. They have more contact with their patients and with people. And sometimes they're the best people to have this conversation, to talk to people about it in just a chat way, and a normal way, as if they were just having a chat about any other part of their care. So
Thank you, Kate.
the people.
Really important, those remarks about honesty and clarity again. I think that's a thread that's coming through the whole conversation. This is one for Upeka. I'd just like to ask maybe the obvious question, how you suggest we maintain the momentum of these watershed times post-coronavirus. Maybe may that be sooner than we all expect, and yeah, we all hope it may be sooner than we all expect. How do we ensure that the culture of talking about life, death, disease, ill health, quality of remaining life, well-being changes more permanently? And this is from Jason Kasimov, who's a senior social worker with Jewish Care.
Well, I hope that keeping the patient or the person at the center of all conversations is a good place to start. I said at the end of my little chat that if we are outraged by poor care and we can empathize with people in distress, I think we are heading in the right direction. I really hope that, like Compassion in Dying, us sharing stories of what patients experience and their families experience will change the way we behave, whether it's about the information we share or the way clinicians interact with patients and families. I think knowing that experience, I hope, would really help.
And Zoe?
I just wanted to share a little bit anecdotally. So I think the culture was already changing before COVID. I think, you know, in Wales, Mark said he's got his Talk CPR, but locally we were having regularly conversations, our respect conversations, every time someone was admitted into hospital. And we've got to the point of a culture change in really only 2 or 3 years, where patients were expecting to have the conversation. They'd perhaps had it with their relatives before they'd come in. They'd had it with a different doctor before they came in on this occasion. And they were less scared. That comment that we made earlier about someone being frightened of a DNACPR form or frightened of a conversation about CPR, that feels like it's shifted locally. I can't speak for the whole country, but it's felt very much like it's shifted locally. And then with all of the press, and as Martin said, with the horrible stories of bad practice with blanket DNACPRs, kind of felt the fear returning a couple of months ago. And I was prefacing conversations with, I know you'll have read horrible stories about it, but what we're trying to do is understand what treatments you would benefit from. It's not that we're rationing treatments. I think what we haven't said in any of this hour and a half yet is that with coronavirus, there was a big fear that this wasn't a decision that was being made in the best interest for the patient. This was a decision that was being made on a rationing basis. And actually, sometimes, of course, there may be situations where that happens. We luckily didn't get to it with coronavirus here, but that's not what the normal CPR or respect decision is about. That decision has to be about what is best for that individual. And I think in terms of talking about this as a watershed moment, I think we as a group have to take the good that could come from this, the destigmatization about talking about death, the increased understanding that CPR decisions need to be made, the increased understanding that it's not just CPR, it's ventilation decisions that need to be made. And you know, what is it that people value? We need to take all of that and make sure that there are personalized conversations while we're still thinking about death, and make sure that we don't have it that people think that it's about rationing in some way, which it isn't.
Yeah, absolutely. Maybe, Zoe, this might also be one for you. I asked that my 90-year-old frail grandmother's GP discuss a DNA CPR with her. She refused it. And when I checked, my grandmother hadn't understood it. I gently turned the explanation from trying to keep her alive and asked her, would you like someone to try and bring you back if you die? She immediately said no and showed full understanding of this. My question is, do we need to change the language we use? This has really helped my practice as a GP discussing these forms with frail patients.
Yes, absolutely. So I absolutely think we shouldn't be asking people whether they want particular treatments. We need to be talking about what outcomes people value. And that might include saying, you know, if you were to die, would you like us to try and bring you back? To which, I mean, I don't think I'm being ageist in saying many people who are very old are quite willing to accept they're at the end of their life and they don't want to keep on going, and that's their choice. And to assume that they would want to, or to make the conversation more difficult, or to make it difficult for them to start it, is cruel in a different way, I think. And of course there are people who do want to keep on going. I'm not making a generalization, but I'm just saying we need to not go need to not make assumptions either way. And therefore we need to make the conversation open, destigmatize it, and talk about outcomes and not just about specific treatments. It's not, would you like a jam donut?
No, it certainly isn't. Okay, I think this one's probably for Mark. CPR training in healthcare settings is mandated, but training about identifying when not to start CPR, having a conversation and making an appropriate record in accordance with the MCA is not. Is this part of the problem?
Yeah, good question. And I just also going on what we've just previously said as well, I found during Corona.
You're cutting out there, Mark. Okay, I think while Mark's cut out, we'll just go on to one for Ed. We're getting lots of questions about the need for shared records. How practically does a paramedic on a 3 a.m. call know about a prior DNA CPR decision? How good is the system? And what about someone away from their home region?
Okay, so I can't speak for the whole of the UK. As I said earlier, there's 13 UK ambulance trusts. We're all slightly different when it comes to what technology is available. What I will say is we're all desperately chasing the best technology, but it's whether it's available in that area at that time. So for example, in London, for example, where the clinicians can access a very useful system there called Coordinate My Care, where people can register their DNA CPR decisions, their advanced care plans, their respect forms, etc. And I know the paramedics on scene can access that from an iPad. That's absolutely where we all want to go, but I'm not saying everyone's at that point yet. And I guess the other thing we've got to recognize, the second part of that question, what if they're not at their home address? The ambulance service works differently to the rest of the NHS in that we work by address. The rest of the NHS goes by NHS number, date of birth, and the patient. We go by where is the ambulance needed. So if you're not at their address where you normally live, it's not going to ping up with the records.
Okay, thank you for that. Let's come back to Mark. Are you back now with a voice, Mark?
I hope so. Can you hear me all right?
Yes.
Okay, so what I wanted to say was, yes, training is vitally important. We have some training resources here, including the Talk CPR videos, but also the ELCA we use and ESR for staff, including nurses, paramedics, doctors on DNA CPR issues. For me, one of the lessons from coronavirus was that there was a frenzy of activity and good and bad conversations when coronavirus started, and we were getting all the information from Italy and from China. And there were some very bad conversations, there was some bad decision making as well. And I think we've certainly learned from that in the process. And I think certainly very early on, we made a statement in Wales, an all Wales statement, to say that even in the absence of a DNA CPR form, even in the absence of an ADRT form, even in the absence of a respect form, for instance, it is still important that the clinician who arrives in that situation can still make a decision. And that might be for CPR, but it might also be not for CPR. So the individual decision-making process in that instant is gathering as much information as you can. Great if there's a respect form, great if there's a DNA CPR form or an ADRT, but if there isn't one, then you can still make a decision at that point in time. And I think that is a very important message that we wanted to convey here.
Thank you for that. This is one for Martin, and fairly swift response, Martin. Please, can you advise why care home staff can be so reluctant to get involved in writing care plans? I'm a GP and I've approached care home managers to ensure proxy access to medical records accounts and encouraging setup for my CMC to involve them and patients in writing electronic flexible care plans. But they've responded, that's the care home, that they don't have the capacity to do this. How do we resolve this?
Well, I think every care centre should have care plans for their residents, and that should be an absolute given. And really what they should also be doing, hopefully, is co-producing those with the person, their families, and also clinicians who are overseeing it. So I would say that go back to them, and if necessary, talk to them from the point of view of what the benefits of this will be to the people who are living in those care settings, and also how it will help them to deliver better quality of care and better outcomes.
Thank you, Martin. And final question for Zoe, and again, a quickie, I'm squeezing it in. Now that patients have to opt out of organ donation, could you see end-of-life wishes, whether to prolong life or to refuse CPR, having to be written down for everybody in the next few years, possibly prompted by the pandemic? And this is from a patient who's had an arrest in the past.
No, is my gut instinct. I don't think so. And I think it comes down to what Ed was saying earlier, which is that it's so hard to be able to distinguish if you don't know anything about the patient as to whether this is a cardiac arrest, in which case you can potentially save their life, or whether this is the final stage of the dying process, in which case CPR can't. And I think the better approach is to make sure that we have good conversations early with patients, with their relatives, and we record it in an easily recognizable way.
Thank you. I think we're coming to the end of our time now. So I'd like to say a huge thank you to all our panelists, particularly for picking up the chairing function when my IT crashed. And thank you to my husband, who calmly came and tried to restore it while I was being horrid to him. And I do have some take-home messages that are kind of, you know, from me. And that's, one of them is about learning from our mistakes, particularly the distress, and that's been relayed to us very clearly this afternoon, that poor communication around CPR causes, not only for patients and families, but also for healthcare professionals and for other care professionals. There is a really important difference between consent and consultation in relation to CPR decisions, and both members of the public and health and care professionals need to be mindful of what that means. And finally, we need to take the time to have honest conversations within families, but also between families and doctors, and patients and doctors. But I really profoundly believe that we can't stop there. Just having the conversation. The decisions made must be recorded. That's the difference between end-of-life wishes being known about and wishes being respected. So I want again to thank all of you, the panelists, and those of you who've joined us, and sorry if you had a little bit of a lumpy experience, but I think we've raised some really thought-provoking issues, and ones that I know we'll continue to discuss online in some way. So thank you for your contributions. Stay safe and goodbye.